Hello guys and welcome back to Count to 10. My name is Arnie and on today's podcast we're going to look at the control of cardiac output and pressure. Now this used to be one learning objective with 4 massive points attached to it. Recently on Mac 95 it's been divided into its own 4 learning objectives. Regardless, all the points we're going to cover are exactly the same. The first thing we're going to look at today are the classic terms of preload, afterload and contractility. Then we'll have a look at the Starling curve and its mechanism, moving on to the Guyton curves after that, and then finally finishing up with the pressure-volume relationship curve. As always at the end, we'll look at the past relevant SAQs from both the ANSCA and the KICM exam. This goes without saying, this is another core cardiac physiology topic with a lot of important diagrams that you have to know in and out that can be asked both in the Viva and in the SAQ setting. So with that said, let's dive straight into it.
1, 2, 3, 4.
The topic today comes under the learning objective, describe the factors that determine and control cardiac output and the implications for clinical practice. So to begin, we'll look at preload, afterload and contractility. Before we can start to describe these terms, we have to understand where this fits in the broader scheme of cardiac output as a whole. So cardiac output is equal to the heart rate times stroke volume. We all know this basic equation. Where we take the next step up is understanding that stroke volume is made up of multiple determinants, and these determinants are controlled by the effect of preload, afterload and contractility. Each one of these terms has a strict definition which can be really hard to rote learn for the exam. So for me, I just break it down into a simple definition. To start, we can say that preload is the force or the load on the muscle before it is activated to contract. What this load is doing is applying a new tension and stretch to the heart muscle, converting it into a new length. That length that we talk about is the sarcomere length. By altering the preload, we determine a new strength at which the heart propels blood forward. So the optimal indice to look at preload would be to measure muscle fiber length. Now we can't do this at a macroscopic level, so we use surrogate indices. The 2 surrogate indices that we use are end diastolic volume and end diastolic pressure. Normally we're just concerned about the preload in the left ventricle. So the way you can get end diastolic volume is by using a transthoracic echo or a transesophageal echo to look at the volume that's in the left ventricle before ejection. The way you get pressure is a bit more complex because you can't just simply measure the pressure within the left ventricle. What you can do is use another surrogate, which is commonly CVP. Here we say that the CVP pressure is an equilibration of the right atrium pressure, which is an equilibration of the right ventricular preload, which is another equilibration of the left ventricular preload. So we're making a lot of assumptions here to get a value for LV preload. This is why when we have a central line in the patient, we can use the CVP as a marker for left ventricular preload, which is then a composite marker to see how underfilled or overfilled a patient is. The trick is not to take one single value, it's to take the trend of the value to give a better estimate. So if preload is the load that's put on the left ventricle before it contracts, aka the volume of blood within the left ventricle before it ejects out, we can say that there's other factors that also help to determine this. We've already said one of these factors is the CVP, so the venotone and the amount of blood within the circulating system. Another factor is the ventricular compliance. If that ventricular compliance is diminished, the volume of blood that can be held within that ventricle is decreased. If the compliance is increased, such as a dilated ventricle, then that preload would be increased. There's obviously a fine balance between too much preload and too little preload, and this relates to the Starling mechanism, which we'll talk about in the next section. Another factor is atrial contractility. Remember when we spoke about cardiac cycle, the atrial contractility contributes to 20% of the left ventricular filling. So if this is compromised, our total amount of blood within the left ventricle is also diminished. Then we have heart rate. If we increase the heart rate, we decrease the time for diastolic filling, again decreasing our preload time. Finally, we have pathological factors that can affect preload. This can be both inflow into the left ventricle and outflow out of the left ventricle. An example of inflow would be mitral stenosis. Now we have a tight orifice, which is decreasing the amount of blood that can go into the left ventricle. An example of an outflow condition would be aortic regurgitation. At the end of ventricular systole, blood is pooling back into the left ventricle. Now it's increasing the preload for the next ejection. So to summarize and conceptualize the factors that affect preload, think about all the factors that will be affecting blood flowing into the left ventricle, whether that's from the inflow tract or from the outflow tract. Now let's define afterload. The simple way to define afterload is the force that the heart must contract against. The more technical definition is the ventricular wall stress encountered as a result of the resistance that the ventricle must overcome to eject blood into the arterial circulation. This is one definition where knowing the term ventricular wall stress is actually quite important. That's because to describe the indice of afterload, we commonly use Laplace's law. Here, for afterload, we say that ventricular wall stress is equal to the change in pressure times the radius divided by 2 times the wall thickness. The change in pressure refers to the ventricular transmural pressure between the inside of the ventricle and the outside of the ventricle. The radius refers to the radius of the left ventricular chamber, and the wall thickness refers to the wall thickness of the left ventricle. If you think about afterload in terms of this formula, you understand why pathological changes occur in the heart when you get an increase in afterload. For example, if you take the condition aortic stenosis, here the heart is putting a lot of pressure to pump blood into the arterial circulation. So the ventricular wall stress is increasing. The way the heart compensates is by increasing its ventricular wall thickness. Now you get the classic left ventricular hypertrophy that you see on an echocardiogram, and this is all a mechanism to help decrease the ventricular wall stress. So when we look at the factors that determine afterload, we can divide it into 3 broad categories. Firstly, it's the ventricular pressure. Secondly, it's the ventricular radius. And thirdly, it's the ventricular wall thickness. Again, these are all just variables from Laplace's law. The main factor affecting ventricular pressure is the systemic arterial pressure. In other words, this is the systemic vascular resistance. This relates to the Hagen-Purcell equation, where we said that the resistance is equal to 8 times the viscosity times the length divided by pi times the radius to the power of 4. Because radius is to the power of 4, this is obviously the most important factor in affecting the resistance and therefore affecting afterload. Other factors that are important to ventricular pressure alone are examples like aortic stenosis, so aortic outflow tract obstructions. This can be both aortic stenosis or HOCM. It can be aortic compliance in general, so as we age, our aortic compliance will decrease because of increased fibrosis and the loss of compliance. And then, importantly for us, we must also understand that intrathoracic pressure is a major determinant of ventricular pressure. With normal spontaneous breathing, on inspiration, we generate a negative intrathoracic pressure. This creates a negative pressure outside the ventricle and a positive pressure inside the ventricle, so the overall transmural pressure is quite large. When we deliver positive pressure ventilation, we now have a positive pressure outside the ventricle and a positive pressure inside the ventricle. This concept is initially quite hard to understand, but that positive pressure outside the ventricle generated by positive pressure ventilation acts as a squeeze to actually help propel the blood forward, so it decreases the afterload. So the overall effect of positive pressure ventilation on the left ventricle is to actually decrease the left ventricular afterload. Now there is a whole host of other effects from positive pressure ventilation that we'll talk about later when we talk about applied cardiac physiology, but for now, you have to understand that basic principle. The other 2 factors for determining afterload that we spoke about are very self-explanatory. So if you increase the ventricular radius, you'll increase the afterload, the classic example being a dilated cardiomyopathy. And finally, if you increase the ventricular wall thickness, you'll decrease the afterload. The classic condition here being hypertrophic cardiomyopathy or just left ventricular hypertrophy. In summary, the key thing to remember about afterload is that it relates to Laplace's law, and we apply that Laplace law to talk about ventricular wall stress. While systemic vascular resistance and the ventricular pressure is the biggest factor, it's not the only factor that affects afterload. Now let's talk about the third important term, which is contractility. Contractility is simply defined as the intrinsic ability of the myocardial fibers to shorten and increase force of contraction independent of preload, afterload, and heart rate. The classic indice we use to measure contractility is the change in pressure over change in time during isovolumetric contraction in a cardiac cycle. So this is the delta P divided by the delta T maximum during isovolumetric contraction. Now there's a few straightforward factors that you think would affect contractility, as well as a few unique reflexes that also affect contractility. The straightforward ones and the main one is your autonomic nervous system. If you increase sympathetic tone, you increase inotropy, and if you increase parasympathetic tone, you decrease inotropy. Another main factor is the circulating catecholamines. So if there's more adrenaline and noradrenaline circulating around, obviously the inotropy is going to increase. The other simple factor are drugs. So we have classic inotropic drugs like adrenaline, or other less commonly used drugs like phosphodiesterase inhibitors such as milrinone, or even more specialized drugs such as levosimentan that are troponin C sensitizers. The two reflexes we talk about are the ANREP effect and the Bowditch effect. The ANREP effect is when there's an abrupt increase in afterload, you get a small increase in inotropy. The reason this occurs is because an increase in afterload leads to an overall decrease in stroke volume. This leads to an increase in end systolic volume, therefore partially increasing the preload for the next contraction. That increase in volume that's left in the left ventricle now produces an increase in inotropic effect for the next contraction. In contrast, the Bowditch effect relates to heart rate. As the normal heart rate increases, you get an increase in ability of the normal sodium-potassium ATPase to keep up with the increasing demand. What this leads to is an increased sodium, which inhibits the normal sodium-calcium exchanger. Now there's more calcium left inside the cell, and if there's more calcium left inside the cell, this calcium can then attach to troponin and lead to an increased force of contraction. These two are very minor reflexes, or should I better say effects, but they do like to ask them occasionally, and they do seem to complete your answer, especially for the SAQs. So that's it for preload, afterload, and contractility, and covers the first part of this learning objective. Now let's talk about the Frank-Starling mechanism. This has a very clear overlap with preload, but still has its own intricacies that you have to know, and has actually been asked as a standalone SAQ in the past ANSCA exams. The Frank-Starling mechanism describes the mechanism by which initial resting length of a ventricular fiber at end diastole determines the force of contraction of the ventricular muscle. In other words, it explains how the cardiac output changes in response to variations in venous return. Now this relationship can be depicted on a graph where the y-axis is tension and the x-axis is sarcomere length. As you can imagine, with the sarcomere length increasing, you get a proportional increase in the tension that's developed. But at a certain point, you get negative returns. This is the point where you get overstretch occurring. Now the normal sarcomere length is approximately 1.8 micrometers. They say that the optimal length to produce maximum tension is approximately 2.2 micrometers. Past this point, you get suboptimal overlap occurring. There are two theories on how the Frank-Starling mechanism works. The first, which is the most likely, is the sliding filament theory. This describes how the overlap of the contractile proteins, actin and myosin, is at a suboptimal level at a resting state. When you increase the preload, you now improve that overlap to an optimal level of 2.2 micrometers. Here you get a better cross-bridging and therefore a greater force generated with each contraction. Past 2.2 micrometers, that's when you get the overstretching occurring. The second theory is that there's increased sensitivity of troponin C to calcium, and that the intracellular calcium increases as preload increases. This leads to the increase in contractile force. In reality, if you know the sliding filament theory, that's more than enough. Taking the Frank-Starling curve one step further, we can substitute the values on the x and the y-axis and replace them with stroke volume on the y-axis and left ventricular end diastolic volume on the x-axis. By doing this, we can more clearly see the relationship of how increasing preload, being left ventricular end diastolic volume, leads to an increase in stroke volume. Typically around the 300 to 400 ml value is when you get the highest stroke volume bang for buck. After that, the stroke volume starts to decrease. Now, if we were to say what other factors affect this curve, we could break it back down to the simple equation of cardiac output equals heart rate times stroke volume. The remaining factors here are afterload and contractility. So you can shift this Frank-Starling curve by either increasing afterload or decreasing afterload. Increasing afterload would shift the curve down, so you get decreased stroke volume, and decreasing afterload would do the opposite, where you get an increase in stroke volume. The opposite is also true for inotropy or contractility. If you increase the inotropy in the heart, so give it positive inotropy, you increase the stroke volume, and if you give it negative inotropy, you decrease the stroke volume. That is the Frank-Starling mechanism in a nutshell. It is simply that a change in venous return will alter your cardiac output. And the main reason for this, we believe, is the sliding filament theory. Now let's take a look at the third part of this learning objective, which is the Guyton curves. The Guyton curves describe two sets of curves that both interplay with each other. They have opposite independent and dependent factors. The first Guyton curve is the cardiac output curve. This is a representation of the total blood flow out of the left ventricle, i.e. the cardiac output. It's depicted on a curve where the y-axis is the cardiac output and the x-axis is the right atrial pressure. Within this curve, the dependent variable is the cardiac output and the independent variable is the right atrial pressure. The right atrial pressure functions as a representation of the preload of the heart. Therefore, this curve is just a graphical representation of the Frank-Starling mechanism. Now, we've already discussed before how the right atrial pressure can be a surrogate for the right end diastolic volume, and therefore a surrogate for the left ventricular end diastolic volume. And what this graph is trying to explain is that if you increase the right atrial pressure, you'll increase the cardiac output to a certain extent at which an increase in right atrial pressure will no longer increase cardiac output further. There are three important points to remember on this curve. The first is the x-intercept. This is where the curve hits the x-axis and where the cardiac output would be 0. Now this point can't occur in real life because when the cardiac output is 0 on this curve, the right atrial pressure is minus 2 mm of mercury. The second point is when the right atrial pressure is at 0. This represents the normal cardiac output of 5 liters per minute. The third point is when you reach peak cardiac output. Here on the graph, this would be when right atrial pressure is equal to 4 mm of mercury, and this equates to 15 liters of cardiac output per minute. Now we know this isn't the max cardiac output that a person can achieve, and we'll get to what other factors alter this cardiac output curve later on. If I was trying to describe this curve to someone in a Viva setting, I would say it has three important components. It has a linear portion, and this is the portion where you get a steep change in cardiac output for a small change in right atrial pressure. Then you get a plateau phase where any further increase in right atrial pressure does not result in an increase in cardiac output. Finally, you have an x-intercept where the cardiac output is 0 and the right atrial pressure is minus 2 mm of mercury. That's your baseline for where you start the curve. So what about these factors that can affect this curve then? Well, because this curve is a representation of the Frank-Starling mechanism, it is essentially a representation of preload. So the remaining factors in our cardiac output equation that can then affect this curve are heart rate, afterload, and contractility. This all makes logical sense. If you increase the heart rate, you increase the cardiac output as per the equation. If you increase contractility, you increase the cardiac output as per the basic equation. And if you decrease afterload, you increase cardiac output. All these things lead to an increase in the plateau at which the cardiac output sits. Under normal conditions, the plateau sits at 15 liters per minute, but with the increase in activity, it can get to as high as 30 liters per minute. Now, the opposite is also true. If you go for a lower heart rate, a lower contractility, and a higher afterload, you decrease the plateau. In my mind, the real significance of this cardiac output curve is that it's showing that the heart has a huge reserve to increase its cardiac output capacity. And while there's multiple factors that affect cardiac output, In a normal resting state, venous return plays the biggest role in affecting cardiac output. So then what's the second Guyton curve? This here is the vascular function curve. In this curve, you have the opposite of the dependent and independent variables. Here, the right atrial pressure becomes a dependent variable and the cardiac output becomes the independent variable. This is a more complex curve to understand because of the certain terminology that's used to describe it. The slight difference with this curve is that the y-axis is actually venous return. It's also in liters per minute, but it's technically not cardiac output. The way I simply understand this curve is that for things to flow, you need a gradient. Something will flow from high pressure to low pressure. The pressure that we're talking about here is the systemic circulation and the pressure in the right atrium. If that pressure gradient is large, then you encourage flow into the right atrium and therefore increase venous return. If the right atrial pressure is high and you make that gradient small, you discourage that flow going back to the right atrium and you decrease venous return. The equation Guyton uses to describe this is that venous return is equal to a term called mean systemic filling pressure divided by resistance to venous return. What is mean systemic filling pressure? MSFP is the pressure at which venous return ceases. So if you imagine you have a cardiac standstill or a cardiac arrest, here you have no circulation occurring, so the pressure inside the vessels would be the mean systemic filling pressure. On the vascular function curve, this is depicted as the x-intercept. Typically this value is at 7 millimeters of mercury. The other important points on the vascular function curve are the steep portion, so this happens between a right atrial pressure of 7 to 0. Then you have a transition zone, and finally a plateau zone, which is between a right atrial pressure of -4 to 0. The reason this occurs is because at a right atrial pressure less than 0, you get the collapse of extrathoracic veins due to the negative intravenous pressure, limiting venous return, which is acting like a starling resistor. Now again, you can't really generate negative right atrial pressures, so these are all theoretical curves, and that's the biggest criticism of the Guyton curves, that they don't actually translate to what happens in vivo. In saying that, unfortunately our curriculum still makes us understand these curves, so we have to know what factors affect the vascular function curve. Just like we said that the cardiac output function curve can be altered by heart rate, contractility and afterload, there are a set of factors that alter the vascular function curve. The biggest one being blood volume. If you increase blood volume, you increase the mean systemic filling pressure, so you shift the whole curve up and therefore you increase the plateau. This is what's happening when you give someone a transfusion. On the flip side, if someone is hemorrhaging out blood, you're decreasing the total blood volume, and so you're shifting the whole curve lower and you're decreasing the plateau level. The second main factor is venomotor tone. This is because majority of blood is actually in the venous circulation, not in the arterial circulation. If the blood volume stays the same, and all you do is either change the tone of the venous circulation to constrict or dilate, this would have the same effect on changing mean systemic filling pressure as compared to changing blood volume. Therefore, if you get venoconstriction, you increase the MSFP and you increase the plateau of the venous return. And then the opposite is true if you get venodilation. A number you can remember here is that with max sympathetic tone, the MSFP can increase to 17 millimeters of mercury. The third factor is peripheral resistance. Here we are concentrating on resistance mainly in the arterial circulation, specifically the arteriolar tone. Now the total blood volume in the arteriolar vessels is actually super small. It only contains 3% of the total blood volume. So changing this tone has very little effect on changing the MSFP. What it does do is change the slope of the curve, either making it slope up higher or lower. What you allow is more blood to flow from the arteriolar section into the venous circulation. The opposite is true if you increase arteriolar tone. Now you have less blood going into the venous circulation, and so you decrease the slope of the curve and decrease the plateau of the venous return. These three are the main three factors that affect the vascular function curve. However, there are other factors that can affect this curve that we'll talk about when we look at the past SAQs. The final thing about these two curves, And the most confusing thing is that these two curves can actually be superimposed on each other to be on the same graph. Because the x-axis is right atrial pressure in both the graphs, and the y-axis is either venous return or cardiac output, they actually overlay quite well. And if you do this, you can see the relationship on how right atrial pressure is key to both changing venous return and cardiac output. An important point on these two curves is where they cross each other, known as the equilibrium point. Normally this is drawn at a right atrial pressure of 0, but in Papano it's drawn at a pressure of 2 mm of mercury. To me, it makes more sense to be at a right atrial pressure of 0 because the cardiac output and venous return are both 5 liters per minute at this level. The benefit of overlaying these curves is we can see how multiple variables affect the curve at the same time. The classic example would be if you take a patient with heart failure. Now normally we've said that the equilibrium, so the intercept between these 2 points, is at 0 mm of mercury of right atrial pressure. If that person with heart failure starts to go into fluid overload, they start to increase their total blood volume. So they increase their mean systemic filling pressure, pushing their vascular function curve higher and increasing their plateau. But at the same time, the heart's ability to contract has been diminished, so you get a decrease in the cardiac output function curve. All of a sudden, the equilibrium point, which is at 0, now shifts, say, to 4 mm of mercury. And this is because the vascular function curve has shifted to the right with an increase in MSFP. However, the cardiac output curve has decreased its plateau because of the decrease in inotropic effect. The overall effect is that someone with moderate heart failure still has the same cardiac output and so therefore can compensate for now. Now, if you take that same person and you push them into decompensated heart failure, you're further increasing the blood volume, so you're further increasing the mean systemic filling pressure to the right. However, there is a further decrease in the inotropic effect that the heart can do. This is where you start to see the effect of diminishing cardiac output despite increasing right atrial pressure. And here you see this in real life where these patients have these really high right atrial pressures, but their cardiac output is suboptimal. Now all of a sudden you're getting compromise in end organ perfusion, leading to end organ failure. Another classic example is what happens with exercise. The effect of exercise has a major effect on both the cardiac output and the vascular function curve. This is because you get an increase in sympathetic activity, which leads to an increase in the plateau of the cardiac output curve, and the increase in sympathetic activity leads to an increase in venomotor tone, so now you have an increase in mean systemic filling pressure. So at the same right atrial pressure, you're getting a major increase in the cardiac output and venous return. So I hope that didn't confuse you too much. I know this took me a really long time to understand, and you really have to look at these curves for a while to kind of let that sink in. As long as you remember which is the dependent and independent variable with respect to which curve you're looking at, and then what factors affect which curve, and remember there's only 3 main factors for each curve: heart rate, contractility, and afterload for the cardiac output curve, blood volume, venomotor tone, and peripheral vascular resistance for the vascular function curve. Now that finally brings us to our last learning topic for today's learning objective, which is looking at the pressure volume loop. We're going to really try to fly through this one so we have some time to look at some past SAQs. The pressure volume loop is a depiction of the left ventricular pressure with changes in volume across the cardiac cycle. The information it can give us is quite immense. It can give us volumes such as end diastolic volume, end systolic volume, stroke volume, ejection fraction. It can give us pressures such as systolic and diastolic pressure, end systolic blood pressure. It can provide information of preload, afterload, contractility, and therefore systolic ejection, diastolic filling, isovolumetric relaxation and contraction. And finally, it can also tell us work that the heart is doing, both the stroke work as well as the stored work that the heart is doing. There's a really beautiful diagram of this curve on deranged physiology that I really advise you to have a good look at. That diagram shows all the important things you need to know of this pressure volume loop. In my mind, the important things you need to know about this loop is firstly, how to draw it. Secondly, understand how a change in preload, afterload, and contractility affect this loop. So to draw this curve, you need to know what the x-axis and the y-axis are. The x-axis is the left ventricular volume, and the y-axis is the left ventricular pressure. You start this curve at point A. This is the point where the mitral valve opens and diastolic filling begins. Here you have roughly 60 mils of volume already in the left ventricle, so this is where you start to draw the curve. From point A, you go to point B, which is where the mitral valve closes. Roughly during this time, an extra 70 mils of blood is being filled into the left ventricle, so the end result is a left ventricular volume of 130 mils. From point B, you go to point C. This is a representation of isovolumetric contraction, so it's the start of systole. Here, all the valves of the left ventricle are closed, so you can't get an increase in volume, but you do get an increase in pressure. The peak of point C represents diastolic blood pressure. At this point, you get the aortic valve opening. Here, you go from point C to point E. Yes, you do skip point D, and point E represents the max pressure that is generated, which is equal to systolic blood pressure. From point E, you're making your way downwards to point D, and this is where the aortic valve will close. Point D will always be higher than point C because there's increased volume now in the arterial circulation as compared to prior to ventricular ejection. Finally, you go back from point D to point A, and here all the valves are closed again within the left ventricle, and you're getting the start of diastole, which is isovolumetric relaxation. This cycle then goes on to repeat itself over and over again. And if you can understand the basic principles that are happening in the cardiac cycle at each step, it actually becomes quite simple. The next step up is understanding how changes in pressure volume loop occur with changes in preload, afterload, and contractility. To me, change in preload is the simplest to understand. This is just a representation of what's happening from point A to point B, because this is diastolic filling. So if you increase preload, you just push point B further. And if you were to draw a line from point A to point B and continue it, this line would be called the end diastolic pressure volume relationship line. Contractility is the next easiest for me to understand. Here, you're just increasing the blood that's been ejected out of the left ventricle. So what you're doing is pushing point D further to the left, so leaving less volume in the left ventricle at the end of systole. The way you show that is if you draw a line from where the X and the Y intercept is to point D, this becomes the end systolic pressure volume relationship line. That line becomes more steeper and straighter as you increase contractility. The one that's a bit more trickier to understand is the effect of afterload. By increasing afterload, you're going to be decreasing the total stroke volume. And the line that depicts afterload is called the arterial elastance line. This line is drawn from point D down to the intercept on the x-axis below point B. That's very confusing to understand. That's why you need to see the curve from deranged and it'll make sense. An increase in afterload shifts that line more steeper and decreases the stroke volume. Now there's a lot more variations we can talk about with a pressure volume loop, such as changes in diastolic filling, systolic function, understanding work, but I do think that's a bit too complex to explain in a podcast format, so it's just best to look at that diagram from deranged, rather than confuse you by talking through a diagram which you can't see. Luckily enough, what that means is that we've come to the end of this mammoth learning objective, and we can actually look at some previous SAQs. There's actually 4 specific SAQs that I want to cover that will hopefully solidify what we've covered in this learning objective. The first one is actually from the most recent exam in 2024 first sitting, where the question was, draw a pressure volume loop for the left ventricle in a normal adult, and the second part was, outline the information that can be obtained from such a loop. The examiner report here is actually quite good, because it tells you what not to do when you're drawing this loop. The main errors came when you mislabeled the points that correlated with diastolic blood pressure, showing improper points of valve closure, specifically noting that aortic valve closure occurring at a lower pressure than aortic valve opening when it should be the opposite way around, incorrectly drawing the afterload and the contractility lines, implying that the whole left ventricular elastance line is preload rather than end diastolic volume, and then incomplete labeling of the X and Y axis. Now, while this question had a pretty good pass rate of 66%, this is core topic, so even with that pass rate, I wouldn't put it past having this question being asked again. It's certainly a Viva question favorite, and therefore if you know this diagram from Deranged, this is a very easy question to answer. So again, drawing this diagram, you have to know your X and your Y axis. So your X axis is the left ventricular volume, and your Y axis is your left ventricular pressure. The whole graph is just a depiction of the cardiac cycle as seen in the left ventricle, with point A being start of diastolic filling, point B being mitral valve closure, point C being the end of isovolumetric contraction and the opening of aortic valve, point E being peak systolic pressure, therefore systolic blood pressure, point D being aortic valve closure and the end of systole, marking the start of isovolumetric relaxation and the start of diastole. Then from the graph you can add 4 headings to the information provided, one being volumes, so these are your end diastolic volumes, your end systolic volumes, your stroke volume and your ejection fraction, your pressure being systolic blood pressure, diastolic blood pressure and end systolic blood pressure, your pressure volume relationship, so this is your systolic ejection, your diastolic filling, your isovolumetric contraction and relaxation, those specific curves that we spoke about. The first one being your end diastolic pressure volume relationship line, which is a way to depict preload and the effects of change in preload. You have your end systolic pressure volume relationship line, which is a way to depict contractility. And then you have your arterial elastance line, which is a way to depict afterload. Then the last heading is area, and here you talk about the energy that each stroke volume takes. Within that you have 2 types of energy. The first one being stroke work, which is the area within the pressure volume loop itself, and then the stored potential energy, which is the area that the whole loop would take, plus all the area under the curve below the end systolic pressure volume relationship line. The reason I think this is a really good question to be asked is because you can put in examples from clinical context. So a classic one being aortic stenosis, leading to an increase in afterload, causing your PV loop to look narrower because the arterial elastance curve is now steeper. Where you take your understanding to the next level is understanding what happens after the first change. So yes, an afterload might increase, but as we've discussed before, an increase in afterload leads to an increase in contractility through the ANREP effect. So if you can convey that on this graph and say, while afterload increase will make this pressure volume loop steeper, the next pressure volume loop for the next cardiac cycle will actually have an increase in contractility to partially compensate for that. The other way they can ask this pressure volume loop is by talking about drugs that we use. So if you give someone an inotropic agent, say adrenaline, here you're going to be changing the contractility curve and therefore increasing your whole pressure volume loop secondary to that. So my advice is to play around with this curve and not only understand what the first effect is, but understand what the knock-on effect is for the next cardiac cycle. Then the next SAQ that I want to look at was from 2022 first sitting, which was define cardiac preload and describe its determinants. I think the most important remark in the examiner report for this question is that defining preload as venous return was a common oversimplification. This usually led to a discussion of the determinants of venous return, and it was difficult to convey understanding of preload and its associated physiological concepts with this restricted focus. Because of that, in the marking scheme, you can see a lot of people hovered around the 2 to 3 out of 5, and the overall pass rate was 44%. So to combat this, my model answer would have multiple factors that affect preload. The definition is simple. It's the force, in brackets the load, on the muscle fibers before it is activated to contract. The main factor is yes, venous return, and a surrogate marker for this being CVP. However, if you think about all the things that affect left ventricular inflow and outflow, I think this way you won't forget all of the other factors. So this is the ventricular compliance itself, atrial contractility, heart rate, aortic pressure, and pathological conditions. All of these can either increase or decrease preload depending on the factors. If you hit all those factors, you'll do fine in this question, and then you can add in the details with each factor. Put in those buzzwords such as the Frank-Starling mechanism, talk about the sarcomere length, but remember, this isn't a question asking about the factors that affect venous return. This is just one part of the factors that affect preload. And I think why this question was really hard to answer is because in 2015, they were asked to describe the determinants of venous return and the effect general anesthesia would have on this. I think this led to most people rote learning the answer for venous return, and venous return is so closely related to preload that it was just a carbon copy of the answer. In that examiner report, it was really important to understand the principles of general anesthesia on affecting venous return, such as positioning, surgical intervention like pneumoperitoneum, our intervention that we do such as positive pressure ventilation on affecting the blood volume, and then the effect of drugs that we use to alter venous return. To answer this question, you could definitely use the Guyton curve as a starting mechanism to draw your understanding of venous return in relationship to right atrial pressure, or you could simply use the equation venous return is equal to mean systemic filling pressure minus right atrial pressure divided by the resistance to venous return. The three main factors affecting venous return being mean systemic filling pressure, venomotor tone, and then peripheral vascular resistance or arterial tone. Each one of these then has its own factors that affect it. So MSFP is affected by the circulating volume. So if you have blood loss in a surgery, this decreases your MSFP and decreases your venous return. If you have a change in posture, such as a patient going to Trendelenburg, this decreases venous pooling and increases MSFP. Giving any patient positive pressure ventilation increases right atrial pressure. Therefore, that gradient that we spoke about from MSFP to right atrial pressure is decreased, and therefore our venous return is decreased. The way we can overcome this is have a patient spontaneously breathing, while with positive pressure ventilation, that gradient is lost and therefore venous return is decreased. The other main factors that you have to put in relationship to general anesthesia is the effect of vasodilation that occurs because of the induction agents that we use, and this leads to a massive decrease in both venomotor tone as well as peripheral vascular resistance. The decrease in venomotor tone leads to a decrease in MSFP, leading to a decrease in venous return, which we offset by using drugs such as metaraminol that both arterial vasoconstrict as well as venovasoconstrict. The last SAQ I want to look at was from way back in 2009, where it was asked, what is the Frank-Starling mechanism, and describe its relationship to excitation-contraction coupling. My model answer for this question is a mix of our very first cardiac physiology podcast, as well as what we've learnt today. And here you would talk about the Frank-Starling mechanism being the intrinsic ability of the heart to alter its force of contraction in response to a change in venous return. The key thing you want to include in this answer is the theories of why Frank-Starling mechanism occurs. So you want to talk about that sarcomere length and the sliding filament theory. And you want to put in the graph that looks at stroke volume compared to left ventricular end diastolic volume. The clear thing you want to demonstrate here is the increase in stroke volume up to the point where you get overstretch occurring, at which point you start to get a decrease in your stroke volume. Then you would incorporate what we learned about excitation-contraction coupling, talking about all the different types of troponin, the different types of contractile proteins, and how all these interconnect with the Frank-Starling mechanism to complete off your answer. Now that was a very whirlwind look at the past SAQs, specifically the ones that I think are really important to understand and consolidate our knowledge of what we've learned today. This was a huge topic in the broader scheme of cardiac physiology, and one that was really content heavy, and I think needs a lot of review of the diagrams that we spoke about today. I want to thank you guys for listening as always. I'll be back next time to cover regional circulation. So until then, Best of luck with your studying and catch you next time on Count to 10.